You know what nobody's talking about right now? The fact that come February, Medicare payments are about to hit a wall that's going to catch millions of retirees completely off guard. And I'm not talking about some minor adjustment or a little bureaucratic hiccup. This is a fundamental shift in how the system operates. And if you're counting on those Medicare reimbursements to flow like they always have, you need to hear this today. Here's what's happening. The Medicare Trust Fund is facing a payment suspension in February 2026 due to the debt ceiling crisis and legislative gridlock in Washington. When the government can't borrow more money, Medicare doesn't just slow down. It stops processing payments to healthcare providers altogether. We're talking about doctors, hospitals, pharmacies, everyone who depends on timely Medicare reimbursements to keep the doors open. Now, does this mean your coverage disappears? No. Your Medicare card doesn't become worthless overnight. Your benefits don't evaporate. But it means the system that pays your providers is about to experience severe delays, and that creates a domino effect that's going to impact your access to care, your out-of-pocket costs, and potentially your ability to get the treatments you need when you need them. Let me break this down in a way that makes sense, because when I first heard about this, I had to sit down and really think through what this means for everyday Americans who've worked their whole lives and are now depending on Medicare to be there when they need it most. This isn't some abstract policy debate happening in Washington. This is about whether you can get your insulin next month. This is about whether your cardiologist will still see you. This is about whether that knee surgery you've been waiting for gets postponed indefinitely. See, the problem isn't with Medicare itself as a program. The benefits you've earned, the coverage you're entitled to, that's all still legally yours. Nobody's taken away your Medicare. The law hasn't changed. Your eligibility hasn't changed. But here's where it gets complicated, and this is where Washington's dysfunction becomes your problem at the kitchen table. The United States government operates on what's called a debt ceiling. And I know that sounds like fancy political talk, but stay with me because this directly affects you. The debt ceiling is basically the credit limit that Congress sets for how much money the federal government can borrow. Think of it like the limit on your credit card, except this is the government's credit card, and the limit is measured in trillions of dollars. When we hit that ceiling, the Treasury Department can't issue new debt to pay for things that Congress has already approved and spent money on. And here's the absurd part. Congress already passed the budgets. They already approved the spending. They already made the commitments. But now they're saying the government can't borrow the money to pay for what they already agreed to spend. It's like writing checks when you know the money's already been spent, but then telling your bank they can't process any new deposits to cover those checks. It's insane, but that's how our government operates. Now, Medicare is funded through a combination of payroll taxes that workers pay throughout their careers, premiums that beneficiaries pay every month, and yes, general revenue from the Treasury. That third component is where the problem comes in. When the debt ceiling gets hit and Congress doesn't raise it or suspend it, the Treasury has to start making impossible choices about which bills to pay and which ones to delay. And historically, when push comes to shove, Medicare provider payments are one of the first things that get suspended. Not because the government wants to hurt seniors or retirees, but because legally they have to prioritize certain payments like Social Security checks, military pay, and interest on the debt to avoid a complete economic catastrophe. The government has to pay interest on its bonds or risk defaulting, which would tank the global economy. They have to keep Social Security checks flowing because those have permanent appropriation authority. Military pay can't stop because that's a national security issue. So what gets cut? Medicare provider payments. So what does this mean in practical terms? It means that in February 2026, if Congress hasn't resolved the debt ceiling issue, and right now there's absolutely no indication they're anywhere close to a deal, the Centers for Medicare and Medicaid Services will stop processing payments to healthcare providers. Your doctor who saw you last week, they're not getting paid for that visit. The hospital that did your surgery, their reimbursement check isn't coming. The pharmacy that filled your prescriptions, they're going to be waiting indefinitely for Medicare to settle up. Think about what that means. We're not talking about a delay of a few days. We're talking about potentially weeks or months of no payments flowing to the healthcare providers who serve Medicare beneficiaries. And Medicare beneficiaries represent a huge portion of many providers' patient panels. For some rural hospitals, Medicare patients might be 60, 70, even 80% of their patient volume. For primary care doctors who specialize in geriatrics, it's similar numbers. And I can already hear some of you thinking, well, that's the provider's problem, not mine. I have coverage. My card says Medicare on it. They have to treat me. But here's why that thinking is wrong and dangerous. Healthcare providers operate on thin margins. Your local doctor's office, they're not sitting on mountains of cash. They've got payroll to meet, rent to pay, medical supplies to purchase, insurance premiums, all the normal business expenses. Most healthcare providers operate on payment cycles of 30 to 60 days. They provide services, they bill Medicare, and they get paid weeks later. That's how the system works. When Medicare stops paying, which represents a huge chunk of their revenue since so many Americans over 65 rely on Medicare, these providers have to make hard decisions fast. Do they keep seeing Medicare patients and hope the government sorts this out? Do they take on credit to cover their expenses? Do they lay off staff? Do they cut hours? These are impossible choices that no healthcare provider wants to make, but they're business decisions driven by necessity. Some doctors are going to stop accepting new Medicare patients. We're already seeing this in areas where Medicare reimbursement rates are considered too low. Doctors in those areas have said, I can't afford to see Medicare patients anymore. The reimbursement doesn't cover my costs. Some are going to stop accepting Medicare altogether. We've already seen this happen in certain parts of the country where Medicare reimbursement rates are low. Imagine that problem multiplied by 100. When payments stop entirely, not just slow down, but actually stop, hospitals are going to delay elective procedures. And when I say elective, I don't mean cosmetic or optional. I mean anything that's not immediately life-threatening. Your hip replacement, elective. Your cataract surgery, elective. Your colonoscopy, elective. These are procedures you need, procedures that affect your quality of life and long-term health. But they're not emergency room level urgent, so they get pushed back. Pharmacies might require upfront payment from Medicare patients instead of billing Medicare later. Right now, you walk into the pharmacy, you hand over your Medicare card and your Part D card, they check your copay, and you pay maybe $10 or $20 depending on your plan. The pharmacy then bills Medicare for the rest. But if Medicare isn't paying those claims, pharmacies might say, we need you to pay the full amount up front, and then you can seek reimbursement from Medicare once they start processing claims again. For some medications, that could be hundreds or thousands of dollars. Physical therapy, home health care, durable medical equipment. All of these services that seniors depend on could become harder to access or require out-of-pocket payment that gets reimbursed later. And that's if you have the cash to front that money in the first place. How many retirees on fixed incomes have an extra $5,000 or $10,000 sitting in their checking account ready to advance to healthcare providers? Let's talk about the timeline here, because understanding when this could happen helps you prepare. The debt ceiling has been a recurring crisis in American politics for years now. This isn't new. It's predictable, which in some ways makes it even more frustrating. We've had showdowns in 2011, 2013, 2021, and several times in between. Each time, Congress has waited until the absolute last minute, played political chicken, scared the markets, spooked investors, damaged America's credit rating, and then finally passed a temporary fix. But each crisis gets worse, the political divisions get deeper, and the willingness to compromise gets smaller. The two major parties seem more interested in scoring political points and blaming each other than they are in actually solving the problem. And meanwhile, real people like you watching this video, are caught in the crossfire. The Congressional Budget Office has projected that without action, the Treasury will exhaust its extraordinary measures sometime in early 2026. February is right in that danger zone. Some analysts think it could be as early as mid-February. Others think we might make it to March or April if tax revenues come in stronger than expected, but the consensus is clear. We're running out of time, and Congress isn't acting. Now, the Treasury has what they call extraordinary measures, which are basically accounting tricks to move money around and buy more time. They can suspend certain investments, like temporarily stopping contributions to federal employee retirement funds. They can delay certain payments. They can shuffle funds between accounts. But these measures only buy weeks or maybe a couple of months at most. They're a Band-Aid, not a solution. Once those run out, if there's no debt ceiling increase, payments stop, and Medicare provider payments are not protected the same way Social Security benefit checks are. Social Security has permanent appropriation authority, meaning those checks go out no matter what. It's written into the Social Security Act. The checks keep flowing. Medicare provider payments don't have that same protection. They're considered discretionary in a debt ceiling crisis, which means they can be suspended. Here's what really keeps me up at night about this situation. We're not just talking about a few days or a week of delayed payments. When Congress finally does act, and they will eventually, because the alternative is economic Armageddon and complete collapse of global financial markets, the backlog of unpaid Medicare claims is going to be massive. We're talking potentially hundreds of billions of dollars in delayed reimbursements. Think about the math. Medicare processes millions of claims every single day. Doctors' visits, hospital stays, lab tests, imaging, prescriptions, medical equipment. Every single one of those generates a claim that needs to be processed and paid. If payments stop for even 2 weeks, you're looking at tens of millions of unpaid claims. If it goes for a month or longer, the numbers become astronomical. The administrative nightmare of processing all of those claims once the spigot turns back on could take months. The Medicare system isn't designed to handle that kind of backlog. The computers, the staff, the processes, they're all built around steady, predictable volume. When you suddenly have to process a month or 2 months worth of backlog all at once, the system bogs down. Providers could be waiting well into spring or summer of 2026 to get caught up on payments from February and March. And that's optimistic. That assumes the system can ramp up quickly and efficiently. That assumes there are no technical glitches. That assumes adequate staffing, all of which are big assumptions. And during that time, what happens to you as a Medicare beneficiary? Well, you're caught in the middle of a mess you didn't create. You played by the rules. You paid your Medicare taxes throughout your working life. You paid your premiums. You're entitled to these benefits, but now through no fault of your own, you might have trouble finding doctors willing to see you. You might face unexpected bills that you have to pay up front, bills you never expected, bills that were supposed to be covered by Medicare. But if the provider needs money now and Medicare isn't paying, they're going to turn to you and say, we need payment at time of service. You might have procedures delayed or canceled because providers can't afford to operate without getting paid. Your prescription drug coverage might get complicated if pharmacies start demanding payment at the point of sale instead of billing Medicare Part D. Imagine going to pick up your heart medication or your diabetes medication and being told, that'll be $800, please, when you're expecting to pay $20. That's the kind of shock that could be coming. Let me give you a real-world example of how this could play out. Say you're scheduled for a hip replacement in February 2026. This is an elective surgery, meaning it's not immediately life-threatening, but it's also not cosmetic. You need this surgery to maintain your quality of life, to stay mobile, to remain independent. Right now, you can barely walk to the mailbox. You're in constant pain. This surgery is about maintaining your independence and your dignity. The hospital looks at the calendar, sees that Medicare payments are suspended, and they make a business decision. They're not being cruel. They're not trying to hurt you. They're trying to keep the lights on and keep their staff employed. They call you and say, we need to reschedule this until the payment situation is resolved, or we need you to pay up front, and we'll reimburse you when Medicare pays us. For a hip replacement, you're looking at $40,000 to $60,000, depending on where you live and what complications arise. Some markets are more expensive. If you're in a major city, it could be even higher. How many retirees have that kind of cash sitting in their checking account ready to go? Even if you have savings, that could wipe out your emergency fund. That could force you to sell investments at a bad time. That could mean tapping into retirement accounts and paying taxes and penalties. Or let's say you have a chronic condition that requires regular monitoring and medication adjustments. You see your endocrinologist every 6 weeks to manage your diabetes. Your A1C levels need to be checked. Your medications need to be adjusted based on your blood sugar readings. This isn't optional. This is about preventing serious complications like kidney failure, blindness, or amputations. That doctor's office does the math and realizes that if Medicare stops paying, they're going to be providing services for free indefinitely. They have bills to pay. They have staff to compensate. They can't operate as a charity. They might tell you that you need to see a different provider, or they might require payment at the time of service with the understanding that you'll be reimbursed when Medicare catches up. Either way, your continuity of care is disrupted. You're seeing a new doctor who doesn't know your history, or you're paying out of pocket and hoping for reimbursement that might take months. Your out-of-pocket costs go up, and your health outcomes could suffer. When you disrupt continuity of care for chronic conditions, bad things can happen. Blood sugar can spiral out of control. Blood pressure can spike. Conditions that were well managed can suddenly become crises. The prescription drug situation is particularly concerning because the Medicare Part D program works through private insurance companies that contract with the government. You're not dealing directly with Medicare for your prescriptions. You're dealing with companies like United Healthcare, Humana, CVS Caremark, and others. These companies pay pharmacies on behalf of Medicare beneficiaries, and then they get reimbursed by the federal government. If those reimbursements stop, the insurance companies are going to change how they operate. They're businesses. They have shareholders. They have bottom lines. They're not going to keep paying out money indefinitely if the government isn't paying them back. They might require higher copays to reduce their exposure. They might restrict which pharmacies you can use, limiting you to pharmacies that have better cash flow and can handle delayed payments. They might demand prior authorization for medications that previously didn't require it. Prior authorization is when the insurance company makes your doctor jump through hoops to prove that a medication is medically necessary before they'll approve it. It's time-consuming, it's frustrating, and it delays care. All of these are ways to slow down their cash outflow while they wait for the government to start paying again. Now, I want to be really clear about something. This is not a Medicare insolvency issue. Medicare is not running out of money in the traditional sense. The Medicare Trust Fund has its own challenges with long-term solvency, and we need to have serious conversations about how to fix that. The Medicare Hospital Insurance Trust Fund is projected to be depleted by 2031, according to the trustees' report. That's a real problem. That needs real solutions. But that's a different problem with a different timeline. That's about the long-term structural finances of Medicare. That's about demographics and healthcare costs and how we fund the program going forward. What we're talking about here is a political failure to raise the debt ceiling, creating an artificial crisis that prevents Medicare from paying bills that it has the funds to pay. It's like having money in your bank account, but the government won't let you access your debit card. The money's there, you just can't use it because of political dysfunction. Medicare has the money. The trust fund has the money, but the Treasury can't process the payments because of the debt ceiling. It's manufactured chaos. This brings me to what you can do to protect yourself, because sitting around hoping politicians get their act together is not a strategy. Hope is not a plan. You need to take concrete steps now to prepare for the possibility that this crisis hits and hits hard. First, if you have any elective procedures scheduled for February or March of 2026, talk to your doctor's office now. Don't wait. Call them this week. Ask them what their contingency plan is. Have they thought about this? Do they have a plan? If Medicare payments are suspended, what happens to your procedure? Ask if you can move the procedure up to January if possible. Maybe you can get it done before the crisis hits. Or push it back to April or May, gambling that Congress will have resolved things by then. Get clarity on whether they would require upfront payment and what that would look like. Would they work out a payment plan? Would they require full payment before the procedure? You need to know these answers now, not when you're being wheeled into surgery. Second, build up your emergency fund if you haven't already. I know that's easier said than done on a fixed income. Believe me, I understand. Social Security doesn't go as far as it used to. Pensions are often frozen. Savings accounts earn almost nothing in interest, but even an extra $1,000 or $2,000 could make the difference between being able to pay for necessary medical care up front and having to go without. Cut expenses where you can. Look at your subscriptions. Do you really need all those streaming services? Can you reduce your cable package?